with the next session, which is on a topic that is very dear to me on mental health. So I'm going to invite Emma to come to the stage and welcome Andrés, who we tried to make to have come here, but without success, and Efobi, who I hope is also connected. So the issue of mental health will have three presentations, and we have an hour and a half, so which makes it half an hour. So what I suggest is we'll do one online, one here, and one online, just to alternate, and more or less having 20-25 minutes presentation so that we have time for discussions. Efobi, are you connected? Are you ready to share your screen? And we start with you.
Thank you very much. Can you see my screen? Can you see my screen?
Yes, we can see your screen. If you could put it in full screen.
Okay. Is it better this way?
Yeah.
Okay. So thank you very much. My name is Uchenna Efobi. So I am making this presentation it's titled. Wait, let me expand it. Okay. So it's titled Exploring the Spillover Effects of Internally Displaced Settlement on the Well-Being of Children of the Locals. So thanks to the conference for inviting us to make this presentation. So my co-author is Ajefo, and he's based at the University of Bradford. So this is the outline of our presentation. So let me just jump in. So what we're interested in this study is to understand how the existence of IDP settlement impacts the well-being of host communities. So our emphasis is on anthropometric indicators of the host community children. Then we also explored mechanisms that underlie this effect. So in terms of what is motivating our study, well, before 2008, IDP settlements in Nigeria were almost non-existent. So as a result of the conflict that erupted in 2010 and upward, there was a number of IDPs that got displaced from their communities, and they migrated into other communities for settlements and also for safety. So in terms of this graph here, it's evidence that that's prior to 2010 there was almost non-existence of IDP settlements, but it's shot up since 2011 and onward. So if you look at also this Nigerian map, these areas that are in green are those areas that that received inflow of IDP settlements. And of course, it is also important to note that these IDP settlements are either in camps or they are integrated into host communities with family members or residents in those host communities. So these areas that are in green are those areas that we were able to identify where these IDP settlements are. Then if you look at this other map here, we you can see that those areas that are in red are those areas with conflict incidents. So what happens is that they move from these local governments, for example, with conflict, into these local governments that do not have, or that are not experiencing as much in conflict. So in essence, there is a clear demarcation between where these IDPs are and where these conflicts occur. So in terms of, we are still on the motivation. So our study is speaking to a vast and oncoming literature that have looked at effects of IDPs on food prices, like Alex Garcia and Vem have studied. Then there are other studies that have examined the backlash from the host communities towards these IDPs. Then there are others that have looked at the effect of IDP on the food system and agricultural production of the host communities, such as George et al. And the likes. Then the one that directly speaks to our study is Bayes 2011, that looked at the effect of refugee inflow on the well-being of children of host communities, and they found that there is a decline in anthropometric outcome by 0.3 standard deviation. There is also an increase in the incidence of infectious diseases, and increase in under 5 mortality. So what our studies is zooming in on is the actual effects of these IDP settlements in Nigeria, which is interesting because there is an increase in national policy and attention on how to integrate these IDPs into the host communities and how to improve their outcomes. So these discussions have been ongoing in the policies circle in Nigeria. So what we are emphasizing is we are studying the effect on child well-being in terms of children that are under 5, which are the most vulnerable, and in Nigeria they comprise of a third of those that are food insecure. Also, they also comprise of those with highest chronic malnutrition, and of course, Nigeria presents an interesting context because it is ranked the second highest. It is ranked the country with the second highest burden of stunted children globally, with a prevalence rate of 32%. So what we are doing is that we used data from the IOM, that's International Organization for Migration, which tracks these IDP settlements over time, and this data also offers a clear geolocation indicators that helps us to identify those communities that host this IDP. Then it also includes the year of displacement and settlement of the majority of IDPs within a certain ward. And in Nigerian political structure, ward is as small as a community in other contexts. So our interest is child well-being in terms of the weight for age, height for age, and weight for height. And we gather this data from the Demographic and Health Survey for 2018 and 2013. So why we use 2018 and 2013 is because that was a period where there was no IDP and a period when the IDPs started to escalate. So we're interested in cohort children, that is children whose birth year are before the IDP settlement moved into their community, and those whose birth year were after when the IDP had already moved into their communities. So we use locational variation as our identification design, such that we measure distance of the household, right, as indicated in the DHS, and the locations where those IDPs are. So we were able to calculate 4 distance bands, that is less than 10 kilometers, between 11 to 25 kilometers, and between 26 to 50 kilometers, and then over 50 kilometers. So why we did this is so that we can identify if the effect that we are measuring declines as the household lives further from the IDP's settlement. And of course, in terms of the control, the control group in quotes, we ensured that we do not include households that are over 200 kilometers. So why we did this is to be able to compare oranges with oranges, and not, of course, oranges and apples in that sense. So from here, we see that in terms, there are some that might be arguing that, of course, as the household stays further from the IDP settlements, they are more likely to be exposed to conflict, and so we will most likely be comparing oranges and apples. But as it is here, we see that there's no much conflict. I mean, the conflict incidents are within similar trend for households that are closer to the IDP settlement, and those that are, about 200 kilometers away. So we are not bothered in terms of us comparing households that stay closer to the IDP and those that, of course, stay further, who may also be exposed to conflict. So what we did is we estimated a difference in difference estimation. Such that we were able to ascertain that there is a parallel trend, right? That the outcomes that we are measuring follows similar trend for the treatment and for those in the control group. And we were able to establish it here. Even if it's not a clear parallel trend, but at least we were able to show that there was no much jump in terms of the outcomes for those in the treatment and for those in the control, using the year of birth of the cohort children as the time variation here. In addition, we also presented a more like an event study graph that shows that in terms of our outcome of interest, in terms of being underweight, stunted, or wasted, that before the year when the IDP moved into the communities, there was no much difference in this outcome for those in the treatment and for those in the control. But after they moved in, we find out that there was an improvement. This is an improvement, right, in the anthropometric outcome, because what we are measuring here is likelihood of being underweight, likelihood of being stunted, and likelihood of being wasted. But we see that it began to drop after the IDPs moved into the host communities. And we also see here as well, in terms of likelihood of being underweight, also there was a drop, immediate drop. Once the IDP started moving in, and also in terms of being stunted, there was also an immediate decline in this outcome once the IDP started moving into the host community. So when we estimated this, what we are seeing is that for those children that are residents within 10 kilometers, we find a higher decline in the likelihood of them being underweight, stunted, or wasted. But this decline began to the intensity of this decline began to reduce once their household are farther away from the IDP settlement. And those that reside 50 kilometers and over, we find no effect. In addition, likelihood of being stunted and wasted, we also see that there are higher decline in this likelihood for those that reside closer to the IDP settlement relative to those that stay farther. And those that are over 50 kilometers, we find in short that there was an increase in the likelihood of being underweight, but in the likelihood of being stunted, we find no effect. So the elephant in the room is, why are we seeing this effect? So we were able to present a correlational evidence that this effect is seen because there was an increase in food prices once this IDP moved into the host communities, and these food prices, these food categories that their prices increase, were those food that are primarily being produced within the host communities. So what happened is that there is an intensity in terms of agricultural production of the household who were originally living in those communities, of course, which also increased their disposable income. That's what we were able to establish here, seeing that most of the food that were being produced in those host communities, their prices increased after the IDP moved in. And when we estimated it, we find that there is an increase in the likelihood of intensity in agricultural jobs relative to other kinds of jobs, particularly for those that reside closer to the host community. Now, there are some that might argue that if there is an increase in food prices, of course, that would also affect the availability of food for host community children. But we are able to establish that in those communities, right, these foods are those that are primarily being produced in this community. So even if there's an increase in food prices, we are arguing that it doesn't affect those that are producing it, because since they're the ones producing it, they are able to access those food, and of course they're also able to increase their household disposable income. Then we also made some argument that there was an increase in aid-related activities in those communities that host these IDPs. As it's seen here, in terms of the World Bank aid, which was what we used there, we find the aid was higher in locations that are closer to the IDPs relative to those that are farther from the IDPs. And when we did our estimation, of course, we used some indicators in terms of vaccination, insect-treated nets, and the likes. We find some evidence that there was an increase in vaccination in locations that are closer to the IDP settlement relative to other locations. So let me just conclude by saying IDP settlement led to improvement in anthropometric outcome of children, of affected children. I mean, children within the host communities, that's what we mean here, and children whose birth years coincide with periods of the IDP settlement in their community. The results we are seeing here is because of a likely shift in household labor activities towards intensifying agricultural production for improved household earnings and an increase in vaccination efforts because of the expansion of donor-led activities in the host communities. Thank you very much, and I am really, I feel that I am losing a lot by not even being on ground to interact more with everyone in the conference. Thank you very much.
Thank you very much. Yes, stay online for the questions after that. Emma, please.
Thank you. Perfect. Yeah. Perfect. Great. Good morning. Thank you very much to the organizers and all the presenters. It's really a pleasure to be here and be able to present this work to you today. Today I'll be talking about how we can work on trying to increase refugees' access to mental health care services. So it's a relatively well-established fact that refugees are at very high risk of mental health problems. And I think we'll be hearing later from a paper that shows that indeed there are effective treatments that exist for refugees that are experiencing mental health problems. But is there a problem? Absolutely, yes. But I'll be talking about how can we try to increase refugees' access to those services. So first, let me just motivate this. Mental illness is actually the leading cause of disability globally, not just among refugees. However, refugees are especially at risk. And indeed, when people are experiencing a mental health problem, it's not only those immediate symptoms that are likely to detrimentally impact their lives. There's also been established a relationship with economic outcomes as well as with child development, which again, I think will actually be spoken about on the next paper. So how can we increase individuals' use of a lot of these low-cost mental health treatments that have been increasingly tested? I'm going to be looking at this in the context of Syrian refugees in Jordan. We've heard a little bit about Syrian refugees, but just to give you a bit of background, there are over 640,000 Syrian refugees residing in Jordan, which is the context that I study. And most of these individuals have been displaced for about a decade or more. So this is a very protracted context, as is common throughout the world for refugees. This is a setting where individuals, again, as is common, have limited right to work. And most individuals live out in the host community alongside Jordanians, not in camps. This is a setting where there's an extremely high mental health burden and yet also very large treatment gaps and knowledge of services. So this is a setting where I show that over 50% of Syrian refugees likely have anxiety or depression. I show this using surveys both with the World Bank and co-authors that have been presenting during this conference using representative surveys. So we've well established that there's a very high mental health need. What I also find is that only about 7% of households are using mental health services. Additionally, very few individuals actually know about where to find mental health services. So again, I survey a representative sample and I find that only 30% are able to name an organization that provides mental health services, even though Jordan is a context where there is a large humanitarian presence. This pace okay? Thank you. Even though Jordan is a context with a large humanitarian presence, and there are indeed for sure mental health services available. Yet, as I said, really a minority of individuals know where they could find those services. And not only are people not aware of formal services, they also aren't using informal services. So most individuals say that they have not spoken to anyone in their network about mental health in the last 6 months. And so this presents a problem that we might first ask, well, maybe refugees simply don't think that they need mental health services or that these services are effective. And so I survey individuals and I ask them first the standard PHQ-9 measure, which is a standard screening of depression, which I've plotted across the x-axis here, standardized just to be 1 to 10. And on the y-axis, I have individuals' self-assessment of how much distress they experience. And what we see in blue is that individuals who are experiencing high levels of distress recognize that. They are aware that they are experiencing high levels of psychological distress. And in orange, what we have is individuals, this is simply a self-report, but individuals' statement of what they think their distress level would be if they were to use forms of mental health services, such as phone counseling. And we see that across the acuity distribution, individuals say that they believe their distress levels would actually be lower if they use these services. Now, this is not, I'm not going to try to convince you that these are immune from report bias or anything of this sense, but simply that I think this is suggestive evidence that individuals are aware of their need and do think that mental health services could be useful. What I'm going to hypothesize is instead likely a key barrier to using services is stigma. So again, in a representative sample of the population, I ask individuals whether they agree with the statement that if I were young and unmarried, I would not marry someone who had ever used mental health services. And so on the y-axis, I have the proportion of people agreeing with this. We see that on average, over 40% of individuals agree with this. And across the x-axis, we have different demographics of the population. And what I'd really like you to take away from this is that whether you're asking younger people or older people, men or women, married or unmarried, you're likely to find quite high rates of agreement with this statement. And we might, again, worry about experimenter demand bias, which I'd like to remind you would actually lead people to likely underreport their agreement with this statement. So I'm going to take this as motivation that stigma is likely a barrier to people learning about services and using services. And so I put forward as sort of the policy problem in this context is how can we help people learn about and access mental health services while accounting for the fact that these are stigmatized services that people might not want to be associated with. The way that I'm going to go about doing that, my approach will have 3 parts. First, I'm going to validate the potential of community-based targeting in this setting. Second, I'm going to look at how we can increase individuals' willingness to share or to send this kind of information, taking into account stigma. And lastly, I'll look at whether people who receive information about mental health services are likely to actually take them up. So how do I go about doing this? I implement a peer information sharing experiment among a sample of Syrian refugees in Jordan. So I start out with a sample of about 1,500, a representative sample of about 1,500 Syrian refugees, and I ask them to nominate individuals who are likely to be sort of central in refugee networks based on the social networks literature. And this gives me a core sample of people who I'll be calling senders. These are really the main individuals in my study. And I have about 850 senders. With each of these senders, I do a social network elicitation specifically with them to identify their relatively close social network. These then comprise the recipients, as I'll be calling them, which is a sample of about 2,600 individuals. And so the general design of the study will be that I'm going to randomize whether I ask these senders to share mental health information over WhatsApp with their friends. So this is relatively unobservable to others. This is a relatively light touch form of information sharing. And you might think, therefore, that this is sort of a lower bound on how much you might worry about others observing you talking about this topic. The content that I'll be sharing is content that was actually designed by the International Rescue Committee in Jordan, specifically to be used to increase mental health awareness among Syrian refugees. So it was very tailored to the context. Additionally, the content includes an advertisement of a free phone counseling service that's provided by a local NGO called the Jordan River Foundation. And I also partner with the Jordan River Foundation to be able to track whether people, specifically the participants of my study, actually take up their helpline. So this means that the two key outcomes of this study will first be whether these senders actually follow through and share this mental health awareness content with their friends and this advertisement of counseling services. And then second, whether the recipients of those messages actually go ahead and use those counseling services. First, you might wonder why community-based senders couldn't we just do this directly from an NGO? And so in order to validate why we might actually really benefit from working closely with the community, I validate a community-based targeting approach. The way that I do this is when I elicit senders' relatively close social network, I also ask them to actually rank their friends in order of mental health need. This might sound quite sensitive, however, individuals trusted that the survey was confidential, and the vast majority of people were comfortable doing this. So they rank their friends in order of mental health need, and then separately, I go and I survey those recipients without informing them about the broader study. And with those recipients, I conduct a PHQ-9 depression screening. And what we find is that senders do indeed have private knowledge of who in their network would benefit the most from mental health services. So what this figure is showing is the distribution of mental health scores, where higher means more likely to be depressed. And in orange, we have the individuals that the sender said were more likely to benefit from mental health services relative to their other friends. Now, of course, you'll notice this is a context in which many people, most people, have very high depression scores. But in fact, those individuals that the sender picks out are about 25% more likely to have depression. Additionally, I won't show the table for this, but I can actually rule out that this can be explained using basic demographic covariates of the exact type that an NGO might use to try to quickly target. And so I take this as strong motivation that, in fact, using these community-based individuals is likely to go above and beyond in our ability to target relative to using basic demographics to find those people who would most benefit from mental health services. So although individuals know who's most in need, we might still wonder, are they actually going to share the content? So I measure whether they share the content in two ways. One is I ask the recipients whether or not they actually got that information from their friends. We might worry that this could suffer from some reporting bias. And so I have a second measure, which is that in all of the content that I shared, I embedded unique trackable links. These aren't going to tell me, oh, Nessa clicked on this link, but it is going to say this link originated from Emma and 5 people have clicked on it. And so this is going to enable me to really have a good validation of whether or not the trends that I find in recipient reports of whether they received the content track to another measure that's very difficult to manipulate. And so what do I find? Well, first, just on average, what I've plotted here on the y-axis is the rate at which a message was received or a link was clicked. And on the x-axis, I have treatment and control, first for the recipient measure, and then second for links clicked. And what we see here is that there's relatively low rates of sharing. So only about 22% of recipients ever actually get this content. And this is in the treatment group. The really small bars are the control group for whom I never shared the information. If we were very worried about spillovers, then we would expect to see that actually there's a very high rate in the control group as well. This is evidence that there aren't really spillovers in this setting, which makes sense given the sort of network structure that I used. So how could we increase individuals' willingness to share this information? Well, one concern is that individuals might worry that if they share this information, there are social image concerns. So what do I mean by that? Well, I might worry that if I tell you about where to find mental health services, you're going to infer or figure out that I've used mental health services before myself, and I might worry about being discriminated against for that. Second, I might also worry that I'm actually going to insult my friends if I sort of suggest to them that they need mental health services by sharing this information. And so what I hypothesize is that people could really benefit from an excuse, or as I call it, social cover. So if you have an excuse for why you're sharing this information, then it can dampen both of these concerns. And so what I do is something very simple. I just encourage some of the senders to tell their friends that they're being paid to share the information. But this is a context in which I'm paying everyone to share the information. So there's no variation in who is being paid. The only variation is in whether or not you disclose to your friends that you're being paid. So I have two variants of the disclosed compensation introduction, which I can get into more in the paper or offline. But in one version, I encourage people to say, this NGO is compensating me to share this information. And in the second version, I encourage people to say, I want to share this information. What do I find? What we see is the higher bars on the left are when individuals are encouraged to disclose information, and on the right is when they're encouraged to say that they want to share the information. And this is about a 37% increase in relative terms. So encouraging individuals to use the excuse that they are being paid to share this information actually leads to a substantial increase in recipients getting the information. I think I'm going to skip over this in the interest of time. How many minutes do I have? 20? Oh, great. Okay, excellent. So we might worry, is this really about individuals worrying that they're going to sort of be revealed to be associated with mental health services? Is that really what this is about? So one thing I do is I explore heterogeneity, and I use machine learning heterogeneity, and I find that there's one characteristic above all else that really predicts whether or not people respond when I suggest that they use this, this excuse. And that characteristic is whether the sender, him or herself, is actually a prior user of mental health care services. And so I take this as suggestive evidence that people responding to having this excuse is really very related to whether or not you've used mental health services before yourself, and you might therefore be especially interested in having an excuse so that your friends don't kind of easily figure out, oh, you are a mental health care user. So how are the recipients themselves impacted? The first thing is that I actually don't find any use of the mental health phone counseling service. And although I have relatively noisy estimates because what I was just showing you on the previous slides are essentially the compliance rate. So compliance was pretty low. So I have relatively noisy estimates. However, I can sharply reject the possibility that individuals use this phone counseling service. What I do find, though, is instead a use of more informal support within these friend groups. Actually, sorry, I don't know if it's within the friend groups, but I find an increase in informal support that these recipients are receiving from their friends. So first, I find large positive effects on social connectedness. So this is coming mainly from individuals saying that they're spending more time helping their friends or being helped by their friends. And also I find a large increase in recipients borrowing. And this is a setting in which borrowing most often happens from your friends, very informally, and oftentimes with little expectation of repayment. So I think of all of this as different forms of social support within your network. I also find a more than doubling of the probability that you've actually talked about mental health with your network in the past 6 months. And the way that I ask this rules out the content of the campaign itself. So this is additional conversations that people are having above and beyond that were instigated, I would argue, by sharing this content or by being asked to share this content. One thing that I won't get into too much, but is the fact that due to the design of the experiment, you can't actually decompose the different framings that I put forward to see their relative effects on recipients because of differential rates of sharing. There are different compliance rates for different treatments, therefore I can't compare the effects on the recipients across those arms. However, I run a follow-up experiment specifically to try to disentangle the primary concern, which is that maybe if you tell individuals that you're being paid to share information, then they might disregard the information that you shared with them because they think, whatever, you don't believe in this anyway. And so I'm able to rule that out in the second experiment. So I'll wrap up here. There are three main takeaways that I'd love for you to get from this study. So the first is that this is a setting, refugee mental health is a setting in which community-based targeting is very promising. And there's good evidence, at least in this context of Syrian refugees in Jordan, that individuals do have pretty good knowledge of who in their network would most benefit from mental health services. Second, I find that refugees are willing to help spread information about these stigmatized services, but there's demand for some kind of social cover or some kind of excuse. And so finding ways to either have the excuse that I used or other forms of excuses, but ways to have people have this social cover for why they're sharing stigmatized information could really help to increase the spread of information about these much needed services. And finally, I find that this light touch WhatsApp intervention does not lead people to take that big step of seeking out formal care, but I do find these promising increases in more informal support. And we can also think of this as sort of a first step in increasing a greater spread of information, which could eventually lead to people using formal services. Thank you very much, and I welcome any feedback by email.
Thank you, Emma. Andrés, over to you.
Thank you so much, Tuan. Can you hear me well?
Yes.
Okay. Thank you so much. And first of all, thank you to all the organizers for inviting me. Terribly sorry that I couldn't make it in person, but at least we have virtual meetings nowadays. And I would also actually like to thank Efobi and Emma, because I think they laid the ground for the topics of that I'm going to be talking about. I'm going to be talking about the link between mental health and early childhood development. So building upon the two presentations that we just saw. And the whole idea is that we're gonna highlight the link and the importance of caregiver mental health by itself, but also as a pathway through which we can protect young children in conflict-affected and displaced settings. And in particular, I'm going to be presenting an impact evaluation of this program called Semillas de Apego, which translates to seeds for attachment or seeds for a healthy attachment. And this is joint work with a big group of psychologists and economists at the Universidad de los Andes here in Colombia, and also at the Child Trauma Research Program at the University of California in San Francisco. So I think like a big motivation, and here I think again building upon what Efobi was mentioning, we know the increase in displacement, refugee flows around the world, but we know here that children have been disproportionately affected. Around 35% of children make up the displaced populations, and within the subset of children, young children, those who are between 0 to 5 years of age, are disproportionately affected because they're the most vulnerable to the effects of conflict and the stress that conflict and displacement bring. So early childhood, the period between 0 to 5 years of age, is the most important stage for skill acquisition, for brain architecture. It's a moment in which we have 1 million neuronal connections per second. It's the most important moment for the foundations of physical and mental health, and for cognitive and socio-emotional development later on. And it's in certain way the most important stage of our life, because it sets the basis for our future life trajectories and for the capacity for us as humans to live healthy, productive, and happy lives. But at the same time, it's also the most important period because it's also super sensitive to stress and adversities. And so for a long time, we've been working on children and emergencies and trying to think, how can we protect, not only trying to think what is happening to these children in these settings, but thinking what can we do to protect these children in settings of conflict and adversity. And this picture, which is by this famous Colombian photographer who has been documenting the horrors and the traumas of war in Colombia, this picture has it all, because it's not only about the child, it's also about what's happening with the caregiver. So when we go back and we look to the literature on early child development, we know that nurturing relationships, the capacity of an adult to create a nurturing environment, a caring environment, to be sensitive to the emotional and physical needs of children, is going to be essential for early child development. And actually, when we look to the literature in terms of successful parenting interventions, for instance, maybe you've seen about the Reach Up and Learn program, the Jamaica home visiting program of the 70s, that's now implemented in many different settings of the world. We know that these programs are successful because they're able to promote this type of nurturing care. And in settings of adversity, like conflict and displacement, these nurturing relationships are going to be even more important because they can actually buffer and regulate the physiological effects of stress and early adversities. So when adversities are coming and start piling up, stress starts building up on both the adults and the children. But if caregivers are there and can provide this type of nurturing care, then the physiological effects of stress are regulated, and this is what's called tolerable stress. The problem is that when children are exposed to systematic and persistent adversities, and when the adults are not able to provide this nurturing care, stress starts building and building and building up, and this becomes toxic. And toxic stress is commonly referred to the overactivation of different biological systems, including the stress response system. And it's going to bring a host of different problems, including toxic stress, including the effects on brain architecture. So this is a figure from some studies in neuroscience from 2 decades ago. And what they're highlighting is the density of the brain connections. So these are the synapses in the brain. And what it's showing you in the top panel is the brain of a child who has been exposed to normal circumstances. And you see that the brain architecture is pretty dense and the neural connections are strong. And in the bottom panel, you can see what's happening when a child is affected by toxic stress when they're exposed to, again, systematic adversities and deficits in nurturing care. And we can see here is that toxic stress is hindering the development of the brain architecture, and it's affecting the strength of the neural connections. And these is going to bring effects that may last for a lifetime. It's also going to affect genetic expression. It's going to affect physical and mental health. And it might lead some of these children into different socioeconomic trajectories, creating mechanisms for the transmission of poverty, inequality, and persistence of trauma across time and across generations. And what we, like our main point, our punchline, is that this is not only thinking of when caregivers can or cannot provide these nurturing relationships, but it's understanding that in some of these settings, or in many of these settings, we're actually asking too much of these caregivers, because we know that conflict and displacement bring about severe mental health consequences on caregivers and other members of the family in general. And this is what Emma was mentioning before. And the consequences, the mental health consequences of displacement are actually going to affect the capacity of these caregivers to create and provide this nurturing care. So in some sense, conflict and displacement are creating psychological constraints that are going to affect the capacity of caregivers to provide this nurturing care. And we can see this using baseline data from our project in Colombia. In this figure, I'm plotting a score of mental health. So a higher score means better mental health. A lower score means more mental health problems. And here we're stratifying the data arbitrarily according to the degree of exposure to different conflict-related events. And so the straight line is showing you those caregivers who at baseline had been exposed to more conflict-related events. And then the dotted line is plotting those who have been exposed to fewer events within a population that is highly displaced and highly conflict affected. And what you can see here is what psychologists have been working on for a long time, documenting this dose-response relationship. So more conflict is associated with more mental health problems. And then we try to do the same, but then paying attention to different outcomes according to the relationship. So we're plotting in the left-hand panel the quality of the relationship between the caregiver and the child, and in the right-hand panel, children's mental health. And now we're stratifying the data according to whether caregivers had mental health problems at baseline. And what you can see here is that those caregivers who had mental health problems, then this maps out into more insecure relationships between the caregiver and the child. And it also maps out into children's mental health. So to some extent, children's mental health is actually mirroring what's happening with the caregiver. And we actually, in a paper that we published last year, we put a little bit more structure into these figures. And what I wanted to highlight here is that we can conduct a mediation analysis, so we can actually try to understand the mechanisms for the effect of conflict on children and displacement on children. And what we see here is that caregivers' mental health is mediating or is explaining between 50 and 80% of the effect of conflict on young children. And this is a setting of again, high conflict and high displacement, as I was mentioning. And despite this evidence, and although we know about toxic stress and we know about caregiver mental health for a long time, when we looked at the space of early child development interventions, and when we look at early child development interventions in humanitarian and conflict-affected settings, mental health and the mental health of caregivers have been largely ignored and neglected. When we look at the successful parenting interventions that I was talking about in a few slides ago, most of them address a different type of constraint. So these are information or cognitive constraints in which the programs come in and provide information to the caregivers on why it is important to, for instance, play with your child, why it is important to become sensitive, how can you do it on a regular basis, how can you create toys from recycled materials, for instance. And these programs in general have been showing pretty positive and sizable effects in vulnerable communities. But the problem is that they actually miss that in these settings of conflict, we should also pay attention to the mental health. Again, that in these settings of conflict and displacement, there are binding psychological constraints that may hinder the effect of some of these other type of more standard interventions, and that might create these loops that we were documenting in the previous figures. And just to highlight a review published a couple of years ago by Pam Jakela, Rachel Nauer, and David Evans in Science finds that almost out of 500 impact evaluations on parenting programs, only 12% actually pay attention or measure caregivers' mental health. And when they do this, it's to try to understand heterogeneity and impact. But this is pretty suggestive and illustrative of the way in which we have missed caregiver mental health in these settings. So to try to fill these gaps, and again, recognizing the importance of caregiver mental health as an outcome, but also as the pathway through which we can protect young children in emergencies. We started working 10 years ago on this program called Semillas de Apego, again, Seeds for Attachment, which is a psychosocial model for caregivers of young children in conflict-affected settings. And we started working in Colombia, focusing explicitly on displaced persons. Then we started opening the scope for other conflict-affected populations in Colombia, and more recently, we also have brought in Venezuelan refugees into the program. And so what the program does is again, it targets and tries to restore caregiver mental health as an outcome, as an important development outcome, as an outcome that has been neglected, as an outcome that in some settings has been considered a luxury, as an outcome that is difficult to target, again, building upon Emma was mentioning, because there's a lot of stigma, there's a lot of misinformation, but it's also a pathway through which we can restore the nurturing relationships between the caregiver and the child. And in doing so, we can attempt to protect young children in these settings. It's based on different theories. We started 10 years ago with our initial curriculum, building upon 2 programs that had been developed in the US for disadvantaged, vulnerable, and underserved communities like Latinx migrants in California. But then we made several adaptations to the local context, including the fact that in Colombia, as in many other cases around the world, we still have conflict. IDPs are still subject to a lot of risk, so we cannot talk about PTSD, for instance. We cannot talk about post-traumatic stress, but instead we're talking about current or complex trauma. And another major adaptation is trying to recognize that in many of these settings, we have deficits in mental health professionals and mental health services. So with this in mind, we designed the program, which is community and group-based model. We have groups of 15 to 20 caregivers, and these are in general caregivers, so it may be the mother, the father, grandparents, some uncles. Most of them, 87% of them, turn out to be mothers of the young children. So we have groups of between 15 to 20 caregivers. They meet once per week over 15 weeks. Sessions last 2.5 hours. And to address these deficits in mental health services and mental health professionals, we train and we hire and we supervise and we support community facilitators. So these are non-professionals that lead the program. And this is important because it not only allows us to overcome these deficits that I was talking about, but it also generates a much stronger connection, I think similar to what Emma was mentioning. Because when the community is actually leading the program, then it creates peer effects, and then you can actually identify yourself and identify your life story in the stories of those facilitators who are leading the program. Because these are also mothers, these are also affected by conflict, and so they're dealing with the same challenges. And so this creates a space for reducing stigma and allowing proper participation and engagement. And over the 15 weeks, the program goes into different sequential dimensions. At the beginning, it works on caregiver mental health. This is to create the space and awareness on mental health in general, and create the space for caregivers then to understand what's happening with children and why these nurturing relationships are so important. And by the end, and to prepare caregivers and participants for the challenges post-program, we also try to improve and promote the construction of parenting teams. All the sessions, just like to highlight, follow the same type of structure. At the beginning, there's an emotional awareness and regulation activity, which is the one that you're seeing here in the picture. So this is one activity that has a mindfulness breathing, like a breathing exercise to regulate stress. Then we dig into a main activity, which is basically a reflection based on arts and craft to ground the information. And this is the figure that you're seeing in the slides. And then by the end, there's a group discussion on how caregivers are going to take these reflections and break them into the everyday practice. So we've been working in Colombia, where I'm based, for 10 years, as I was mentioning, and we conducted the impact evaluation in a municipality called Tumaco, Colombia. As the map on your right is highlighting, it's a municipality in the southwest of Colombia, and the border with Ecuador and the Pacific coast. It's geographically rich. It's culturally incredible. The population is mostly Afro-Colombian. It's a gorgeous municipality. It's also one of the municipalities in Colombia that has been most affected by conflict and displacement, because 65 to 70% of the drug trade coming out of Colombia is actually coming through the port of Tumaco. So from the jungles in the rural areas through the rivers that come into the urban area, and then through the port to the Pacific. All this drug trade is coming and going to either the US, Mexico, or Europe. And so different armed groups have come to try to control the municipality, and as a result, the civilian population has suffered. It has very high rates of homicides. It has very high rates of displacement. It also has very high rates of poverty, as you can see in the stats in the slide. I'm not gonna bother you with details in the experimental design, but it was pretty challenging to conduct this experiment. How do we engage with the communities? How do we reduce stigma so that they're willing to participate? How do we ensure the safety of participants, facilitators, and operators, and our own team in a setting of active conflict? But here I can show some of the descriptives. In total, we have 1,400 caregivers who participated in the program. Half of them were assigned to receiving the program, in addition to the services provided by childcare centers. Half of them only received the services by these centers. 96% of the participants were women. 82% had been victimized directly at least once in their lives. 57% of them had been internally displaced at least once in the previous 5 years. And when we look at the data at baseline, we see that 27 and 16% of them had symptoms of depression and anxiety problems at baseline, respectively. And then on your right, what you can see is that this community model and the level of engagement allowed us to break some of that stigma and reluctance that, again, we were seeing in Emma's paper. And what you're seeing is that on average, participants were invited to the program, go to 11 sessions out of 15. And what you're seeing in the histogram here is that the majority of them come into the program and then remain for 12, 13, 14, and 15 sessions. So it has, I think, compared to other programs, relatively high dosage. In terms of data, we collected a battery of different scales according to the program's theory of change. And so caregiver mental health, the quality and the style of the caregiver relationship, and then children's mental health and early child development. And let me just start wrapping up and reporting the results. So here I'm plotting the point estimates and confidence intervals at the first follow-up, which happened 1 month after the program ended, according to these 5 main dimensions. And what you see here is that at the first follow-up, we are not seeing much in terms of caregiver mental health. Would we start picking up positive, sizable, and statistically significant effects in terms of the quality and the type of the interaction between the caregiver and the child? And we see also positive effects in terms of child development. And this creates a little bit of a conundrum, because the whole story that I've laid out to you is that we need to restore caregiver mental health in order to be able to promote children's development. And here we're seeing that there's positive improvements in children's development and the type of interactions, but not on caregiver mental health. And there's different competing explanations here, but one of them, which is similar to some psychoeducation programs, is that these programs take a while for you to see the effects on mental health, because they're creating awareness of the different problems. And so as you're creating more awareness, then people are going to be more inclined to report more problems of mental health. But at the same time, they may be becoming better able to regulate their emotions. Now, what happens, and I think what's more interesting and reassuring, is that 8 months later, we come back, and what we're seeing here is positive results and statistically significant results across the board. So 0.18 standard deviation improvement in caregiver mental health, a 0.27 standard deviation improvement in the quality of the relationship. So reducing stress in the relationship and improving this type of nurturing care and sustained effects on children's development. To try to provide a little bit of a more intuitive way of understanding these results, at the 8-month follow-up, for instance, we see a 38% reduction in the likelihood of experiencing symptoms of phobic anxiety. Phobic anxiety is closely tied to the manifestations of trauma related to conflict. It also reduces in 32% at-risk symptoms of parenting stress. And it reduces between 27 and 35% symptoms of anger, anxiety, and behavioral problems for the children. So these are sizable effects. And again, effects that pick up over time, even as the program ended 9 months ago. A couple of additional mentions, and I start wrapping up. We see two different dimensions of heterogeneity. One is that there's stronger impacts on caregivers who had mental health problems at baseline. So this is highlighting that the program is working the best for those for whom it was designed. But it also has smaller impacts, still positive, but smaller impacts on food insecure households. And so this is highlighting this Maslow hierarchy of needs. It's probably very difficult for these families who are food insecure, who are struggling to bring food to the table on a daily basis, for them to have the capacity and the bandwidth to then sit down on a program to reflect on their emotions. And this creates some questions in terms of whether you need some sequential or complementary type of programs. And some preliminary evidence about cost effectiveness. For each dollar that we invest in the program, we can get between $3 and $12 of social return under different scenarios. Now, based on these positive results, we started scaling up. We started testing the feasibility and validity of testing this, of scaling this across Colombia. And as I mentioned, we started moving from a focus only on displaced populations to wider populations affected by conflict, and nowadays also with Venezuelan refugees. And we have the program that's being implemented currently in 11 municipalities, reaching 2,800 participants and a team of 66 community facilitators. And my final slide, I think what we're highlighting here, and again, connecting with what we saw in the two previous presentations, we are highlighting the urgency of addressing mental health as an outcome itself, but also as a pathway to protect early child development in these settings. Unfortunately, we still invest very few resources on early child development. We still invest very few resources on mental health. And in this paper and this project, we're demonstrating that we can address both dimensions within a unified lens and a unified program. And similar to what Emma was mentioning, this is not limited to this context. It's important for displaced populations. It's important for your conflict-affected populations, but the lessons are not limited to this context. Just considering the burden of disease in terms of mental health and how they affect different dimensions of our lives. Thank you so much.
Thank you very much, Andrés. I'm going to collect a few questions to start the discussion. So raise your hands for the microphone. So one, two, and three.
Yeah. Thank you very much for the presenters. I'm Professor Kwadju Kwame, medical doctor, professor of medicine.
Can I help you? No.
And also senior member of Pan-African Research Council. Thank you for the three presenters. I have a question for Emma. Emma, when you were summarizing your research, at the end you said for IDPs, you said they need social cover before sharing mental health information. So can you explain it a little bit for us? Thank you.
Thanks a lot. 3 fascinating papers. Question for Efobi. I was wondering if you could look at the farmers, the people who were farmers at baseline, because given the heterogeneous effects of prices, so obviously you also have sort of sectoral change. It's really interesting. But if you picked up sort of a larger effect among people who were farmers at baseline, I think that would give additional evidence for your mechanism. And then Emma, I'm wondering if you've got any sort of information on like just the information channel that is available here. So there's a social Stigma channel, but like alternative program would be like IRC just handing this out information like to all of their clients as they come. And so just wondering if you have any thoughts on either a follow-up with that to compare or just sort of descriptive data from your fantastic work. Thanks a lot.
Thank you, the 3 speakers. It was a fascinating session before the keynotes. So I have a question for Emma and one for Andrés, if you don't mind. So for Emma, my question is connected with, do you have some data on characteristics of the network members that might facilitate the spread of information and some creation in new networks, right? Those that receive the mental health program, there might be some willingness to interact among them, if you could develop a bit more. And for Andrés, connecting with Emma results, right? I mean, can you observe a peer effect given that you're willing to scale it up? I mean, taking into account some transmission among peers, but also those that receive the program, what is going to happen for them and for those that are surrounding them? Thank you.
Thank you very much to all the presenters, and great to see you, Andrés, online, and thank you for your present. It's always a pleasure to listen to you. I wanted just to ask a confirmation to my understanding. When I looked at the plot where you were showing the caregivers, the effect on caregivers and the effect on children, where we were seeing very little progress on the caregivers' mental health. Is my understanding from what you were saying is basically the fact that they were becoming aware. They may not have improved their mental health, but the fact that they were becoming aware was having already a great effect on the child mental health. But then when you showed the 8 months later, I saw the interactions had kind of regressed, right? And I wondered what that meant. So that's it for me. Thanks.
So we'll start with Andrés since the question is fresh, and then we'll come back here.
Great. No, thank you so much, and for the kind words. Yes, we do see that so we have again the explanation that you picked up in terms of the program tries to create awareness on mental health, to try to normalize mental health problems as a normal reaction in a very abnormal circumstances and traumatic circumstances, and at the same time to provide emotional tools for emotional regulations. And so our main hypothesis is that what's happening at that 1 month follow-up is kind of these two opposite forces are balancing out. Now, what we see in the second follow-up, as you picked up, is that the interactions, the point estimate is smaller. We cannot reject that they're different, but actually these interactions refer to positive and negative discipline. So the type of interactions caregivers are having with their children, and not so much in terms of the stress that's happening in the family, not so much in terms of the self-efficacy that caregivers identify in terms of whether they're able to become caregivers and lead and provide this nurturing care. And so to some extent, the program is mostly working on the dimension of the stress and not on the interaction. So I think it's also reassuring that we're seeing that the effects in terms of the stress are becoming even like larger and more sustainable over time.
So I'll pass on to Uchenna. I'll read questions that were online that are kind of complements to what Thomas was suggesting. And it's mostly about alternative outcomes and whether you can look into that. So how do internally displaced settlements impact the access to education and healthcare for local children? And what are the long-term consequences on their overall development? The second question of those outcomes is also, in what ways do cultural exchanges between IDPs and local children influence their socialization, identity formation, and potential for conflict or cohesion within the community? And then the online questions ends with, what do you think is the role of local governance and international organizations to mitigate those spillovers?
Thank you very much, Thomas. So I think I will just start with his suggestion. I think it's an excellent one, since we're finding that there is an intensity in agricultural production. So I am assuming that we will most likely see heterogeneous effect across farmers at the baseline. So I think that is one idea I would take forward in updating the paper. So so we would look into that. Then in terms of alternative outcome regarding access to education, yes, I think that will be interesting, especially because these areas where these IDPs, where these conflicts occur and where these IDPs move into, they predominantly have low educational outcomes in Nigeria. That is northern Nigeria. So so I think it will be interesting to see if the inflow of IDPs further stresses the educational system in the host community. So that's an idea, I think, for another paper that we would take forward. Then cultural exchange between IDPs and local children. Now that is very interesting, but I think we need to also understand that these IDPs, they move. I mean, there's no much cultural diversity in terms of where they are moving away from and where they are moving into, because this conflict is domiciled in northern Nigeria. And if you look at the map that we earlier presented, they move from one local government to another neighboring local government. So we might not be seeing much cultural shock, especially compared to if it's a cross-border IDP that we are talking about. But that's not what we're talking about. We're talking about IDPs that move from a community to a neighboring communities. But of course, this is an idea that we can further examine. Then in terms of role of local governments, that's also very interesting in Nigeria, because the local government, most times they are not as powerful as the state's government. So even if they have the capacity to do some integration efforts, the initiative doesn't always stem from bottom up. Instead, it is an initiative that is first of all promoted by this state government or the federal government, and then it affects the local community. So in terms of if they have the capacity to do much, I think I would say they don't really have the capacity to do much. In fact, there is an experiment that we are currently conducting in IDP camps, And most of the contacts that we are currently engaging are from the state government and from the federal government. They are more involved in terms of what happens to the IDPs compared to the local government in Nigeria. So that's what I would say to these questions, and thank you very much.
Thank you very much. Over to you, Emma.
Great. Thank you so much for the questions. Starting on this side, so I think the first thing to clarify is this was actually a study with Syrian refugees residing in Jordan, so there were no IDPs involved in this study. What do I mean by social cover? This is a colloquialism, so I apologize. The meaning here is some kind of excuse. So something that's going to prevent you from having your own social image or how people regard you being tarnished by your choice to take this action. And that's really what I'm testing in this study, is whether it seems that people are worried about having their reputation be tarnished if they talk about mental health services, and that having an excuse seems to help evade that concern. Great. Thomas, thanks so much for that question, because I actually tried to do that. So this was actually something great, I think, that came out of the learnings of the study was, so Thomas was asking, why not just sort of blast this information out to everyone? So I guess you mentioned maybe handing information to people. So I guess if your face-to-face beneficiary base is large enough, go for it. However, what we tried was sending information directly from the NGO as sort of a blanket guarantee that you're going to get this information approach. And the original idea was to actually compare that to the community members. People reacted very negatively to this, and it was not feasible, which I think is actually very important to learn. People were quite freaked out. Like, why do you have my number? We used the IRC name, which is well known in this context, but nonetheless, people really did not like this. So I think it's actually, more evidence for why it really makes sense to work with community members in this context. And then, can you just remind me of your question briefly? Right. Yes. Great. Yes, thank you. So on the second part, in terms of whether new relationships would be formed, I don't think so, because here I'm asking people to share information within their pre-existing friend group. And as we see with, I sort of test for spillovers by looking at whether information is shared in the control, and very, very little information is shared. So I don't think that there was much crossover across friend groups. In terms of whether there are characteristics of individuals, so actually, great question. So I do find that recipients who have higher baseline mental health need are more likely to receive the information from their friend. So I should have actually mentioned that. So not only do the senders have the information that they could target with, I actually find evidence that they do target with that information. And within the senders themselves, I actually find very little heterogeneity, that different types of senders are better or worse at sharing this information. Although I do find that some types of senders are actually more willing to engage with the NGO than others. So no difference in how willing they are to get the information to their friends, but if you wanted to sort of establish more of a connection on sort of a long-term relationship as an organization, then I have results that speak to that as well. Great, thanks. There was also a comment online that I'd love to address.
Yes, I'll get to it. On the second round, is there any other questions in the room?
Yeah, so very nice session. I do have a question. I'm here. I have a question for Emma about the scalability of the intervention. Could there be contexts where actually getting money to spread information is also stigmatized because you're just a person that are paid to share information about something that goes against the norm? So that could also be the source of a new source of stigma. So I don't know if you have any thoughts about this. And also, if you have thought on how this could interact with informal providers of mental health that are not these westernized services, because in many settings there simply do not exist. There are no mental health providers, and then population often relies on these informal leaders or religious persons, etc.
I think there's a question here. So this is also for Emma. I think one major takeaway from your study is that social norms are kind of a binding constraint, right? And so a natural question is how do we need to think about ways of changing social norms, and have you thought about it? Related, we know from work on gender-based violence that community leaders have, when messages come from community leaders, for example, on GBV, they carry a lot more weight than messages that come from others. And I wanted to know whether you can exploit some of that in your data. If I understood correctly, elicited the senders, they seem to be all kind of central nodes. So I don't know how much variation you have in how central those central nodes are, but it will be interesting to explore whether those that are, and maybe this for a different study, but whether messages that come from really central people in the local network have a stronger effect than from just coming from your friend. And kind of just the last thought that I had, I understand why you wanted to do the social masking things. Is of course I get that, but to some extent it also undermines a little bit the acceptability, right? If we're thinking about changing social norm, right? If I tell someone, well, do that, and I'm giving you information, just somebody paid me, right? I basically signal implicitly that I don't endorse it, and hey, we're playing just a game, like some NGO is giving me money, so I'm just like, passing it on. But like, it's actually, one can argue that it's not only masking, but it's also signaling something that goes against what you want to communicate. So I wanted to hear your thoughts about that as well.
And for Uchenna, I just wanted to ask about whether the prices of the agricultural products are stabilize, because as production comes up, you would naturally expect maybe the prices also to come down. And what does that mean for continued agricultural productivity in the region? I know it's just about 3 years, so maybe the window is fairly short, but it would be interesting to see how that continues.
So before giving the floor to Emma first, reflecting on one of the questions and following also on Guy's point, if Andrés and Emma, you could also reflect on the ethical issues, because we know mental health is a very sensitive topic, and we have this principle of do no harm, and a questionnaire, an intervention, and the fact that people are reacting signals that there's some discomfort due to the intervention itself. So can you reflect on either the specifics of the ethical issues of your experiment, or more generally on interventions in the mental health space, and especially Andrés, when it comes to children?
Should I go ahead? Oh, yeah. So I think super important, and actually connected with some of the comments in the chat and in the room in terms of scaling and communities. So we do see deficits in mental health services, formal services, mental health trained personnel. The idea here is that we can address this through a community-based model. So these are professionals, but this creates a question in terms of, are you opening a can of worms in terms of motivating participants to becoming aware about their mental health problems without actually providing adequate support? What happens when you have, and so this is psychosocial, right? So this is not like a clinical intervention. What happens when you then come come about with more critical cases, and how do you do this, right? And so the whole process in Semillas, it's like a layer, like a layered strategy. We have the facilitators who we train, and training is experiential. They have to go through the program before they can lead it. Then there's very intense supervision, but the supervision is not focused on whether they're checking some boxes or doing some activities, but rather on their own emotional well-being as they lead the program. This is the whole caring for the caregiver model. We care for the caregiver so that they can take better care of their children. Who cares for them? Facilitators. Then we care for the facilitators so they can do this properly. And this is something that, for instance, with NGOs that we've partnered, they say, well, the supervision system is maybe too expensive or too time-consuming because it happens over a weekday. And why don't we cut this out, right? But this is what we've seen is a way of ensuring that the team of facilitators is appropriately trained and supported. But then in addition, we have teams of psychologists that when we start identifying critical cases, the teams of psychologists come in, and then we have a whole protocol that may eventually lead into remitting these cases to municipal health services and so on. But what's, I think, challenging here is that in many of these cases, when we actually ask local authorities, public health systems to provide support, they usually come back to us saying we are actually unable to do this. So this is creating this challenge in terms of like a very unmet needs, very important needs that are gonna map out into different dimensions. Here we're highlighting how it affects children's development, but it also affects behavior. It might affect the socioeconomic integration, many other dimensions that have been studied in the literature. But it's challenging in terms of how do we do this in an ethical way.
Thank you, Andrés. Emma, over to you.
Great, thank you so much. And I think there was a question in the chat that was very aligned with sort of the same sentiment of two of these questions. So I'm really glad you brought this up. These are the right questions to ask. So first, I think an important question is, where did this intervention even come from? And it actually came from observing individuals in piloting. So what I found in piloting was that individuals, when asked to share information with their friends and not suggested to disclose that they were being paid, this was just being paid a very small amount to compensate them for their time and the airtime costs of sharing information, that people continually kept sending the instructions that we were giving to them. The instructions that said, here's a reminder that we're paying you and please share this with your friends, and now send the information below. And then we'd see that people would share their instructions with their friends. And we said, okay, they must be confused. So we added a big line of asterisks, and we said, below this, send that content to your friends. Of course, don't send them the instructions. That'd be so awkward. Why would you tell them that we're paying you? And we found that time and again, people chose to send these instructions to their friends. And this is what really motivated this design, was evidence in piloting, at least, that it really seems like people in this particular context, given the stigmas that exist, really perhaps wanted to get information to their friends about how to access these services for a real need that their friends have. And yet the social norms in this context are that there is a lot of stigma around doing so. And so this was a context in which that seems to be a way that people were able to evade the stigma that existed. Absolutely, trying to actually reduce the existing stigma is really important. That's something that I'm hoping to work on quite a bit more. And it's something that I think has actually perhaps been a bit understudied in the literature, because I think there's been a focus on settings where people misperceive stigma. So there's been a focus on settings where people say, everyone thinks that there's a lot of stigma, but all we need to do is let people know that actually their friends are okay with mental health. But this is a setting where there is a lot of stigma towards people who use mental health services. People are saying, I might not want to marry you if you use these services. And so figuring out, in a setting where there's the reality of stigma, how do we still connect people to services? And that's really what this study aimed to do. happy to talk more about this offline.
Thank you, Emma. And the final words for you, Uchenna.
Thank you very much. So in terms of prices of the agricultural products being stabilized after the period of our study, we really did not investigate that, and we really cannot speak to that. But I think let me just draw some insight from what we did. What we did was we looked at conflicts that are not most of the conflicts that occurred when we studied this when this IDP started to increase were non-resource based conflicts. They were mostly militancy and insurgency in the northern region of Nigeria. But since 2016, there were most of the conflicts started to be tied to land conflict, resource-based conflict. So I think if we look at the prices of food in those areas in Nigeria, as of now, it has also increased. I mean, the price has increased, but there has also been the reason for the increase is as a result of low agricultural engagements, because most of the conflicts are now tied to the fact that that headers, right, are engaging in conflict with resident farmers. So of course we can say that the prices did not stabilize. Instead, it kept on increasing as a result of the shift in the motivation for the conflict. I don't know if that makes sense, but that's what I can just say about this question.
Thank you very much. A big thank you to the three presenters for a very exciting discussion. So I invite you to the coffee break, short, so that we can come back and listen to the keynote speak.